Welcome, everybody. Please be patient. We're waiting for other colleagues to join. We have a lot of delegates today for our second joint action webinar. So if you just could be patient with us, and we'll begin quite shortly. So we're very excited to present this second webinar and to have you all join us, maybe for the first time, maybe for the second time. But we're still waiting on a good number of our colleagues to join, so please be patient. And it won't be too long before we kick off to what's really an interesting, exciting range of speakers today on a very topical area that continues to challenge us in terms of risk assessment, risk communication, and risk perception in this field of secondhand smoke and aerosols. So I'm just going to check how we are doing for the numbers, and we still have a good number of people to arrive, so people are still taking their time. So just bear with us for a few minutes, and then we'll be able to kick off. And so if you're just arriving, please wait for a little while. We're just waiting for some more colleagues to arrive. I'm just watching the numbers of people arriving. Once it steadies, we will open the event. But at the minute, I think people are still just finding their way virtually into the room. So just be a little bit patient with us for what really is exciting for us, because what we want to do with the joint action is to bring you on the journey of the joint action and to allow you to look into the work that we're involved in, but also for us to reach out to you and to encourage you to look at our website and to link with us and to collaborate with us on this or future initiatives so that we can all build a tobacco-free society. So you're just looking now at the numbers. So the numbers seem to be stabilizing. So just give it one more minute, and then I think we're going to go to the event. Look, I'm going to kick off because I think the numbers seem to be stabilizing. So I want to welcome you to this second joint action webinar. It's an exciting collaboration between the European Commission and the European member states. I want to ask you to notice that there's a Q&A panel on your screen, and you should put questions into that panel as we go through this interesting seminar, and they'll be picked up at the end in a panel discussion with all of the speakers and all of the chairs. And we hope that we can develop a dialogue which will be of value to us going forward. So without further ado, I want to introduce you to Professor Esteve Fernandez from the Catalan Institute of Oncology, who's widely known and respected throughout the world of tobacco control. And Esteve, you're very welcome to give an overview of your vision of this seminar, which you really have brought together.
Thank you very much, Maurice, Dr. Mukai. I believe we have a great opportunity in this webinar to show an excellent sample of what European collaboration, thanks to the funding of the European Commission, is able to do. Here we are going to show recent results on indoor and outdoor exposure to secondhand smoke and also to secondhand aerosols from electronic devices from a past European project, the TAX project, and also together linking it with the joint action on tobacco control, the second joint action, and what we are doing within the joint action, because one of the work packages is about smoke-free environments, and we will be also presenting very early results, more or less preliminary results about a consultation. So putting together these two big projects, the TAX project and the joint action, is a very good opportunity to offer to the tobacco control community in Europe and abroad last messages, and also not to present but also to discuss. This is another important topic in the webinar. Our intention is to provoke discussions using, as Maurice commented a few minutes ago, the questions and answers panel. So all of you attending, about 77 people right now attending the webinar, can use the Q&A tool of Zoom to do your questions in any moment, they will be contemplated and put at the end of the presentations. So don't wait at the end of the presentation of the speakers, but can do at the same time that the results are shown and the comments are done, your Q questions. So thank you very much. The only thing is to thank, I believe, Work Package 4 from the Joint Action on Tobacco Control, who is organizing these webinars. Also, in our case, the Work Package in charge of smoke-free environments, and also all our institutions in Ireland, in Italy, and also in Spain. So thank you very much. I pass the floor to Dr. Maurice Mukahi. Again, thank you.
Thank you, Esteve, for that overview. So we could just pull up the slide with the agenda for the first session, which I'm delighted to chair. And this session is going to look at the current status of secondhand smoke and secondhand aerosol, as Esteve mentioned, in Europe. And our first two speakers are Silvano Gallis and Alessandro Lugo. Silvano leads the Laboratory of Lifestyle Epidemiology of Mario Negri Institute in Milan. He was the professor at Nottingham University, Associate Honorary Professor between 2017 and 2021, and he has had a long career, 25 years, with extensive experience in conducting independent research and collaborative work in the fields of epidemiology and public health, and of course in tobacco control. And he's an author or co-author to nearly 400 peer-reviewed journals. His colleague, Alessandro, and you're both welcome, holds an MSc and a PhD in biomedical statistics. She trained as a research fellow at the Mario Negri Institute in Milan, and she actually leads the Institute of Biostatistics on Observational Epidemiology. And our fields of interest, which are relevant critically to today, are the monitoring of major risk factors of cancer and other non-communicable diseases. And you'll remember, if you were on our first webinar, we spoke a lot about non-communicable diseases, and we hope shortly to have the videos and the slides from that presentation available on the Joint Action website. So our main fields of interest include major risk factors and in Italy and Europe, and obesity and the use of novel products. So with that, I want to welcome our two speakers, and I'll hand over to Alessandro and Silvano, and we're very much looking forward to speaking to you, hearing from you.
Thank you very much, Maurice, for this presentation. I leave the floor to Alessandra for the beginning of this presentation.
Yeah, I'm sharing the presentation. Okay, so good morning to everyone. So the structure of the presentation of today is about the methodology of the study from which we derive the results I will show you. I will mainly show two key results about the exposure to secondhand smoke in Europe and exposure to secondhand aerosol from electronic cigarette in Europe, and then I will leave the floor to Silvano, who will provide you the conclusions and recommendations from our study. So very briefly, the survey we conducted within the TOUCH project was conducted in 12 European countries, which were strategically selected to represent approximately the 80% of the European population. It was a face-to-face survey conducted with a CAPI mode, and it was conducted in 2017-2018. We collected information from about 1,000 individuals in each country. So we had a final sample of approximately 12,000 participants, and they were representative in each country of the general population aged 15 years or more in terms of sex, age, and other characteristics. In particular, we focus our attention to two subsamples of these overall samples, and in particular, we had more than 8,500 non-smokers, so never and former smokers combined, and this subgroup was the basis of the results on secondhand smoke exposure. And then we had more than 1,600 e-cigarette non-users, and this is the basis of the results of the exposure to secondhand aerosol. Since the survey was conducted 5 years ago, we had a small proportion of e-cigarette users, since e-cigarette was not so common in the countries considered, apart from England. In our questionnaire, we had a specific section focused on collecting the information on exposure to second-hand smoke and second-hand e-cigarette aerosol in indoor setting. So we focus our attention now to indoor settings. In particular, we had 5 indoor settings, 3 private settings. They were home, workplace, or educational venues for students and private transports, and 2 public places. So we had public transports and other indoor setting, which included cafeterias, bars, restaurants, and other hospitality venues. In each of these 5 indoor settings, we asked people to report the time of the exposures in terms of minutes per day to second-hand smoke and second-hand aerosol separately. So we considered a person exposed to SHS or SHA if he was exposed at least 1 minute per day. So at the end, what we have as the outcome measure of our studies was the daily, let's say daily exposure to second-hand smoke or second-hand aerosol in indoor settings. So regarding the exposure to SHS in Europe, we observed an overall prevalence of 31% of exposure to second-hand smoke in any indoor setting among non-smokers. This prevalence was higher in men than in women, and we observed a huge variability across the 12 countries considered. So we in the map, we can see the 12 countries. Those colored in light gray were those with the lowest prevalence, and the lowest one was observed in Ireland, 24%, and the countries colored in dark gray are those with the highest prevalence, reaching a maximum prevalence of SHS exposure in Greece, where we found 68% of non-smokers exposed. And the median time of exposure was 60 minutes per day. Likely this variability, this heterogeneity reflected also the difference in terms of implementation and enforcement of different tobacco smoking legislations in the different countries. So we have an overall prevalence of 31% in all the 5 places considered, and then we have 15% of exposure in leisure facilities, in hospitality venues, 13% at home, 11% in workplaces, and less common in private public transport, where we observed 5 and 4% of people exposed respectively in these 2 settings. We can also analyzed the prevalence of SHS exposure in the 5 different indoor settings by country. I don't enter in details, but then if you want to see some details, I can show you. Just to show you that also within each of the 5 settings, we observed some heterogeneity across countries. So at home, in workplace, public and private transports, and in other indoor settings. We also analyzed the determinants of second-hand smoke exposure in indoor settings, and we observed, as I mentioned before, that men were more frequently exposed than women, that young were more frequently exposed than the older generations, and that those with a lower socioeconomic status were more frequently exposed also. Second-hand smoke exposure was more frequent in former smokers than never smokers, in those using electronic cigarette, and in people perceiving that second-hand smoke exposure is not harmful for their health. Regarding the exposure to second-hand aerosol of electronic cigarette in Europe, we found that among those non-using electronic cigarette, the exposure to second-hand aerosol was 16% in in the 5 indoor settings combined. Also in this case, men were more frequently exposed than women, and the exposure ranged between 4% in Spain and 30% in England. And the median duration found was 33 minutes per day. Again, we analyzed the determinants of the daily exposure to second-hand aerosol, and we found that men, the young, and those with a higher level of education were more frequently exposed, and also past users of electronic cigarette, current smokers, and again, those perceiving that second-hand aerosol exposure was not harmful for their health. We also analyzed the country-level determinants, just to mention that, as expected, we found higher prevalence of exposure to SHA in those countries where the use of electronic cigarette was more prevalent. Then I leave the floor to Silvano for conclusions and recommendations.
Thank you, Alessandra. Yes, well, we have seen that at the end, 1 in 3 adults, more or less, almost more than 30% of non-smokers in the European Union are still exposed to second-hand smoke in indoor settings. And this is despite the implementation of comprehensive smoke-free legislations. We need, therefore, to increase the enforcement of smoke-free legislation and also the monitoring of these legislations. This legislation should be targeted specifically to vulnerable subgroups, including in particular the younger generations and people with a lower socioeconomic status. Next slide. We observed that despite the relatively limited use of electronic cigarette in our population, less than 3% of the adult population in Europe declared, in fact, to be user of electronic cigarette. Despite this relatively low use, there is a substantial proportion, 16% of non-users that are exposed to second-hand aerosol of electronic cigarettes in indoor settings at a daily basis. Therefore, our recommendation is to include electronic cigarettes in smoke-free laws, and also in this case, these legislations should be comprehensive and targeted to vulnerable populations, in particular targeted to young people. A possible explanation of this relatively high proportion of exposure to second-hand aerosol is the misperception of both users and non-users of electronic cigarettes in Europe that second-hand aerosol is simply steam, and therefore a vapor, a harmless vapor, not harmful for human health. Next slide. So if we consider these estimates we found that 1 out of 4 adults in Europe were current smokers, and approximately more than 30%, and therefore 1 out of 3 non-smokers are exposed daily to second-hand smoke. Therefore, we can say that in Europe, each smoker in average exposes daily approximately 1 non-smoker to second-hand smoke. The numbers are different with reference to second-hand aerosol of electronic cigarette. In fact, 2.4% of adults were electronic cigarette users in our population, in our study, and among those non-users of electronic cigarette, the proportion, the prevalence of adults exposed to second-hand aerosol was 16%. Therefore, in Europe, each electronic cigarette user in average exposes daily more than 6 non-users to second-hand aerosol. This should be taken into account. We highlighted this aspect in a commentary published recently in the Lancet Regional Health, Europe. Next slide, please. These are the publications or the manuscripts available on this issue. We published in early published this publication on second-hand aerosol of electronic cigarettes in tobacco control. We have already ready a manuscript on second-hand smoke, but we didn't submit it yet because of several reasons. Now the data are becoming older and older, and therefore we want to publish this data as soon as possible. Next slide. And these are the other two publications on the prevalence of smoking in Europe, in 12 European countries, and the prevalence of electronic cigarette use in 12 European countries. Next slide, it is just a thank for the attention. This is all from us, and we wait for questions. I give back the floor to Maurice.
Thank you very much for that very interesting presentation. I'm encouraging people still to go to the Q&A panel and to give us some questions for the end of the session. But I have a couple of questions maybe for Alessandro and for Silvano. In your view, do you believe the routine information on secondhand smoke and secondhand aerosol collected by the Eurobarometer is enough for monitoring purposes, for instance, for the Empower model that we use?
Well, we believe, I can try to answer, we believe that the Eurobarometer is a very important tool, extremely important for us, and we need to use it also because it is publicly available. It is true that at the end, it is not completely enough when we look at specific topics of interest. For example, we were able to enter more in details with this specific multi-country survey we conducted. And therefore, it is an extremely important tool, but probably not enough, in particular for evaluating specific topics of interest. I don't know, Alessandra, if you have something to add.
No, nothing. Just to say that the Eurobarometer takes into account in recent volumes the exposure to second-hand smoke and also, in a sense, second-hand aerosol, even if it considers together with the exposure to heated tobacco products exposure. In selected settings only. So, for example, they consider bars and restaurants, or maybe inside the airports or malls, and also in some outdoor settings. What we tried to do was to be as comprehensive as possible to provide a complete picture on these topics. But of course, Eurobarometer is a really essential tool.
Okay, we have a question in on the Q&A, if you allow me. Did you look for differences between countries with and without laws banning the use of e-cigarettes in all places where smoking is forbidden? So did you look for differences between countries with and without laws banning use of e-cigarettes in all places where smoking is forbidden?
Now, I don't remember, Alessandra, if we considered at least the tobacco control scale, the component of the tobacco control scale of 2017, 2018, when the fieldwork was conducted, in order to see. I'm quite sure that we considered it, and I remind to the paper published in Tobacco Control in order to see the association between secondhand smoke exposure and this component of the tobacco control scale. Alessandra?
Yes, in the paper we analyzed the tobacco control scale score in general. So we divided the countries according to their score, and we found that regarding exposure to secondhand aerosol, that countries with a higher score were those with a higher exposure to secondhand aerosol, but this was mainly due to England, because England, UK has a very high score, and also it was the country with the highest prevalence of exposure. But then when we consider the adjusted odds ratio, we didn't find any statistically significant difference. Also, at that time of the survey, I don't remember exactly, but maybe countries didn't ban the use of electronic cigarette inside, because the use was still very rare at the time 5 years ago. But I'm not sure.
So one more question, because we are good for time, and I thank Manfred Neuberger for the last question. Your results show that many indoor settings are places where non-smokers report exposure. What do you think is next at the European level to prompt legislation at the EU level?
Well, we believe that there is room to increase the enforcement of these smoking, smoke-free legislation. So because also in Italy, for example, we observed that more than 10% of non-smokers are exposed daily to secondhand smoke in workplaces, and this should be avoided at least. I believe that, moreover, we are ready now to talk about tobacco-free outdoor settings, let's say, because in specific outdoor settings, we recommend that smoking should be forbidden, like in the bus stops or in gardens and parks of municipalities. And there are some examples, like in Milan, I must confess, in Milan, my city in Italy, showing that this is possible. This is already possible in many cities and in many countries.
Thank you, Silvano. I might move us along so that we can get to our next speaker. So thank you very much for your wonderful presentation. And we will see you on the panel discussion shortly, so don't go away. And then hopefully nobody else is going away, because I now want to introduce you to our next speakers in this session. They're going to speak to us about the exposure to secondhand smoke in open places in Europe. And we're going to listen from Elizabeth May Henderson and from Maria Jose Lopez. So Elizabeth May and Maria Jose, you're both very, very welcome. It's good to see you both on screen together. So Elizabeth May Henderson has a BSc in biology and PhD, is a researcher at the Preventive Interventions and Program Service of Barcelona Public Health Agency. Her area of research relates to the evaluation of interventions in public health, mainly tobacco control policies. And she's joined there and now by Maria Lopez. She has a PhD in public health and biomedical research, and she's the head of evaluation and intervention methods service of the Public Health Agency in Barcelona. And she has led and participated in many projects and has over 100 scientific papers at stage. I'm sure there are more to come. And she's an associate professor at the Pompeu Fabra University, which I hope I pronounced properly. So you're very welcome. We really look forward to your presentation, and I'll hand over to you.
Thank you very much for the presentation, Maurice. Okay, we're trying to share the slides. Oh, I think. Let's try it again.
Yeah, I'll try sharing again.
¿No es el PDF?
Sí, porque no está el PDF. Digo, para que salir del modo presentación y volverla a cargar. Sí. ¿Qué me queda aquí?
So, yeah, 1 second. Okay, let's try again.
Aquí, en la flecha.
Okay, now can you see it well?
Yes.
Okay, great. So,
Yeah.
okay.
Okay, thank you for the presentation. It's a pleasure to be here today. I am Elizabeth Henderson, and together with Dr. Maria Jose Lopez, we will be presenting the results for 4 different studies, 4 published studies, in which we have assessed secondhand smoke exposure in different open settings using reported measures, but also objective measures in Europe. Before we move forward, I would like to stop and take a minute to explain what is secondhand smoke exposure, though I'm sure most of you already know, but secondhand smoke exposure is a complex mixture of substances that are released into the environment when tobacco products are used and that contain carcinogens, toxic components, and irritants. So it's very important to keep track of secondhand smoke exposure and levels or presence in our environment. And this is what we did in the TACS project. We assessed secondhand smoke exposure in different urban outdoor settings in 11 European countries. Those that you can see listed in blue in the slides and also highlighted in blue in the map. So the countries we assessed were Bulgaria, France, Germany, Greece, Italy, Ireland, Poland, Portugal, Romania, Spain, and the United Kingdom. In our exposure assessment, we prioritized some outdoor areas, of which when we checked the smoke-free legislation, we observed that it was partial or inexistent for most of the European countries we were targeting. So we prioritized children's playgrounds, terraces and hospitality venues, and the immediate outdoor entrance to primary school buildings. And what we did, we timed our visits, our fieldwork to the usage of each area and to the affluence of people in each setting. And we took 20 samples per setting and per country, being half of the samples in more deprived areas and the other half of the samples in the least deprived neighborhoods. How did we measure secondhand smoke exposure? We used we assessed the concentrations of an objective marker, which is nicotine concentrations in the environment. And in this first picture, you can see here in this slide, it's the device we used to sample these concentrations, the nicotine concentrations in the environment. As you can see, there's a plastic capsule. This capsule contains a filter that was treated to capture nicotine concentrations specifically. And as we wanted to expedite our time of sampling, as we were sampling in outdoor areas, we connected this monitor to an air pump. And this is the other part of the device you can see in the picture. Our second image in this slide shows one of the forms we used to gather information on our second outcome, which was the visual evidence of tobacco-related consumption items. This one specifically was designed for children's playgrounds, and we gathered the presence of smell of tobacco smoke, the presence of people smoking in the area, also the presence of discarded cigarette butts, and in some cases, the presence of ashtrays. So this is a quick overview of the process we would follow to take nicotine measurements. First, we would assemble our monitor and the sampler and connected it to an air pump. Then we would carry this monitor in a backpack to not draw many attention, and we would open the air pump and start monitoring while we are noting down the visual evidence of tobacco consumption. And finally, we would retrieve the filter in the monitor and send it to the laboratory to be analyzed and to determine nicotine concentrations. I'll move on now to the results for our first setting, which is children's playgrounds. Here you have some of the pictures of the settings we sampled nicotine concentrations in the different countries. And what we found in children's playgrounds, we found 18% of the playgrounds had detectable smell of tobacco smoke. People were smoking inside the playing area in 1 out of 5 playgrounds visited, and immediately outside the playing area, less than 1 meter away, in 1 out of 4 children's playgrounds. We also found discarded cigarette butts in more than half of the playgrounds we were visiting. And in terms of nicotine concentrations, we found detectable levels of nicotine in over 40% of the playgrounds. This same graph here shows the same items as the previous one, but in this case, comparing playgrounds according to the neighborhood's socioeconomic status. And what we observed here is that for all the different items related to tobacco consumption, the presence of these items was always higher in those playgrounds that were located in more deprived neighborhoods, being these differences significant in the case of the discarded cigarette butts inside the playing area. Also, in terms of nicotine concentration, we found higher median nicotine concentrations in those playgrounds that were located in more deprived neighborhoods. I'll move on now to show you our results for the primary school entrances. Here are some of the settings, some of the sites, that we visited in the different countries. And this graph is similar to the one in playgrounds. And we found in the entrances to schools, they had 30% of the entrances had smell of tobacco smoke. More than 40% had people smoking in the outdoor entrance. And 3 out of 4 entrances also had discarded cigarette butts. We found ashtrays in roughly 15% of the entrances. And in terms of nicotine, we found detectable levels of nicotine and thus presence of secondhand smoke exposure in 46% of the school entrances. This graph here shows the same items I was showing before, but comparing the school entrances according to the neighborhood socioeconomic status. As we had observed in playgrounds, we found all these items had higher presence in those schools that were located in more deprived neighborhoods, being this difference significant in the case of the presence of smokers in the entrances, implying a lower denormalization of tobacco use in educational venues that are located in more deprived neighborhoods. And now I'll leave the floor to Dr. Maria Jose Lopez, and she'll continue to explain our results for the terraces of hospitality venues and the results for the reported measures.
Thank you, Eli. Okay, so let's go to terraces of hospitality venues that, as you will see, they are like, let's say, very different from their previous setting. Here you have the tobacco signs in terraces of hospitality venues. As you can see, we found people smoking in nearly all the terraces of hospitality venues in all the countries, more than 92%. And equally, there were a smell of smoke in 82% of the cases, but in nearly 3 out of 4 terraces, and also ashtrays of nearly 90% of the terraces. In this case, when we look at the nicotine concentrations, we found nicotine presence in 94% of the terraces that we studied. And importantly, in more than half of these terraces, the nicotine concentration that we found exceeded those found in smokers' homes. Also, something that we think it's very important is that in all terraces where smoking was banned, we found presence of nicotine and people smoking. It means a clear non-compliance with the law. And finally, also to say that in terraces with a minimum of 2 sidewalls and a cover, regardless of smoking being banned in most of the countries that we studied, airborne nicotine levels tripled those found in smokers' homes. So we found really very high concentration, even if it's supposed to be an outdoor setting. And just to show the last data that we have, we wanted to show you some results that come from the survey that Silvano and Alessandra coordinates. I think someone was asking, some assistant was asking in the Q&A if they have results in outdoors. So here you have the results that we analyze in collaboration with them. What you have here is in the dark color. What they did was to ask to the smokers if they have been in this setting during the last 6 months and if they have smoked there. While in the blue line, what you can see is the answer when we asked to the non-smokers if they have been in this setting, if they have seen someone smoking. No? So first thing that we see is that all the answers are very consistent. No? Smokers and non-smokers more or less have the same perception. And as you can see, for instance, in children's playgrounds, we found around 40% that is exactly the same data, no? that Ellie said for nicotine presence in these settings. So children's playgrounds and outdoor areas of schools is where we found the lowest perception, but still half of the people have seen someone smoking. And maybe just, well, they ask about the stadia, parks, outdoor areas in hospital, public transport, sports, and you can see from 55% stadia until 70% in public transport stops. And so one of the settings where the percentage was higher were, again, terraces of hospitality venues, and also beaches that were actually the setting where most people have the perception of this secondhand smoke exposure. So, well, just to tell you that all this data and many data, like much more in detail, have been already published. They are the part of the brilliant thesis of Ellie. So all of them are open access, so you can just download them from free and consume whatever you might need. And just 2 slides before finishing, just to share some thoughts that I think that are important. No? It's why are we concerned about the smoking in outdoor spaces Many times it's said like, well, outdoors, the level of exposure probably is not very high. Maybe it's not that important in terms of public health, but I think it really is. It is. On one hand, well, we have to remember that there is no safe level of exposure to secondhand smoke. So if there is exposure, there is some risk. And also, as we have seen in some settings like terraces, where the density of people and the density of smokers can be very high, and the levels of concentration that we found are really high, extremely high, more than in homes of smokers. Also, the second reason that I think it's also very important in terms of public health is the thing of the visibility of tobacco use that goes against the normalization of smoking. We know there is that the scientific evidence is very clear regarding that those children who usually see smoking have a much higher risk of becoming smokers. So I think we have to be like very aware with this thing, and try to be clear in this thing, that smoking is not the normal thing, and we have to give this message. Also, now we always talk about the global health, and also it's important to remind that tobacco use, tobacco consumption, it might have it has a significant environmental impact. Now we know that bats and so on, it takes many years for them to be degraded, and it has a very important impact. And finally, as we have seen, now in those neighborhoods from the most deprived areas is where the prevalence of secondhand smoke exposure is much higher. So we know that for many risk factors, for many health problems, the lowest social class have a higher prevalence, and we are like adding another health inequalities with the secondhand smoke exposure. And we think we have to put efforts to fight against that. So I think that from all these results, it's very clear that we have to move towards smoke-free outdoor areas. On one hand, in those areas that are already regulated, we think that it would be a good idea to establish some type of perimeter and to put clear signposting. So it has to be very clear when it is where it is allowed smoking and where it is not. And also, it's not enough to have a law written in a paper, no? So we have to do campaigns, we have to explain why we do that, no? And with this equity perspective, and we have to monitor what is happening, and we have to put efforts in enforcement. So if there is non-compliance, we have to do something about it. And finally, also we have to advance in implementing more smoke-free outdoor areas, and I think we have to ban smoking in many other outdoor settings. And that's also, hopefully we will have more and more smoke-free settings. Thank you so much.
Thank you, Ellie and Maria, for a very interesting presentation. And some things change and some things stay the same. And what struck me is that where secondhand smoke goes, e-vapor will go. So the issue of smoke migration is still around, and the issue of maybe concentration of secondhand smoke in outdoor areas allowed for smoking is high. And so we have the issue, we're concentrating smoke and aerosol in areas where it's allowed, and then it's migrating. So it's a reality check. It's an issue of risk assessment, the work that you've always done and continue to do so brilliantly. And it's an issue of, I suppose, risk perception and risk awareness raising. And this great work that you've done on outdoor areas, I think, is just showing the way that we have a problem and it just doesn't go away because we change the setting. The problem is still there. So if you had funding to conduct a new study, and I know you'd like this, where would you, based on the results, what other outdoor areas or maybe indoor areas and what measurements would you now move to?
Well, may I say something and you can add wherever you want. Well, we usually say with Esteban, Silvano, and so on, that we would like to have a touch project too, no? Like the second part, because we still have a lot of work to do. And there are many places, no? When we look at this last slide of all the settings that we studied with the survey, it would be like very nice to have also objective measurements of all these other settings that we have not included in touch, no? One setting that maybe we should like to study more in detail, and because we saw this result, no, in the survey, that beaches are one of the places where nearly everybody says there is people smoking. And we have to say that we did not include this setting in this study, but recently in Barcelona, there has been an initiative where at the beginning they like banned smoking in some of the beaches. So we have the opportunity to study, no, what was happening. We didn't have nicotine measurements, but we have observational signs. And we see that the prevalence was very high at the beginning and how the percentage of smokers there nearly disappear. It has a very good, most people in Barcelona was very happy with this idea. And this year, all the beaches will be smoke-free. So, I mean, it's very important to have data of all these settings to be able to monitor what's happening and to evaluate potential initiatives and so on. So beaches would be one setting, but all the others of this list, I think they are very important, no? Also is Stadia, for instance, no? That is a place where we are supposed to do health promotion, no? Physical activity and so on, but we are always smoking. It makes no sense, no? And it would be nice to have like more data on what's happening in these settings.
And this raises the issue too of the behavioral change that we try and bring in some areas of public health, that you can bring a horse to water, but it may not drink, you know, the line people use. But to try and change behavior and to nudge people to continuously stay with good behavior is problematic for us, I think. And I think that only with this visibility that we make of invisible products by the measurements is one way that we work. But I cut across you there, Ellie. You were about to come in.
Yeah, no problem. I was gonna echo what Maria Jose was saying. I think Stadia is also an important setting to target and to have measurements. And beaches, of course, we have seen this initiative in Barcelona with great acceptance. And yeah, I think it's a value for the city. I would maybe add healthcare centers and hospitals, because it's banned in some European countries to smoke on the outdoor areas, but still there is low compliance, and we must always remember it's places where vulnerable people go. And also because we need health promotion and prevention in hospitals and healthcare centers. So just to add this thing to the long list that we would prioritize for the tax project too.
Do you feel that the messages for smoke-free have got tired? But we've been fighting this battle for so long, many people on this call and the delegates. It's the messaging has been around for so long, and many of the things that we see are still the same. Do we need to reinvigorate the way that we deliver our messages, do you think? And now with the European Cancer Plan, we have a new platform for bringing the awareness of the real issues that come from secondhand smoke, burden of disease, which maybe has been forgotten because it got washed away by other public health challenges like COVID and other things that come and go. So do you think it's time to find a new prominence in the landscape for an environmental risk that is obvious, that we know of, but we have become, you know, we have switched off to?
Yes, I think so. Actually, with this initiative in beaches, I remember that they were like thinking a lot in what type of signs they put. Like they didn't want to put the typical forbidden smoking, no, but I don't know, no? A fish with let's do this environment better and things like that, no? Like more in a positive way, no? Because we are always like, you are gonna be ill if you smoke and so on. So changing a little bit. I also have to say that at the beginning, these signs were so, let's say, so ambiguous that some people were like, what's the message? And we have to change it again. But I think we have to change a little bit the way of we say things. And also very important, also to include this equity perspective, because the message is it's not always the message because it's the structural things, but well, I don't know. I think we have to rethink a little bit on this message.
We have a few minutes, and it came up in the earlier discussion from Silvano's group. But the issue of vulnerable groups has come through, and the inequalities of exposure and the vulnerable groups smoking in the home has been an issue that is always pushed to the back of a lot of conversations. But there are high risk groups, that you found and that you come across. So is there more in terms of research that we could do in terms of the high risk groups? You mentioned earlier about hospitals, but I'm thinking of children, and maybe children with maybe underlying respiratory illness, and there are other people. Is there more that we should do in a more pointed way with our research, do you think?
Yeah, I think we could target some of the population, but I always keep in mind that there is no risk-free exposure, so you never know. So we should aim for complete smoke-free areas for everyone, healthy and not healthy or more vulnerable. And in line with what Maria Jose was saying, I think we should frame our message that smoking, reframe this in a positive way, as she was saying, but also put a focus on denormalization, because sometimes you're like, as a smoker, okay, I won't be able to quit because I don't feel I able to, but I don't want to think that my kids, because they see me smoking, will be smokers in the long run. So I think we should emphasize also this very key element of smoke-free areas, which is like denormalizing this behavior and adding it to other tobacco products. So it should all come in the same package.
Okay, very good. So I might bring this session to a close because we are getting up ahead of steam, as we say, for a good panel discussion. And soon my colleague, Dr. Renato Salmini from the National Center on Addiction and Doping will lead the session too. So we might bring up the slide for Renato. And Renato, I'm delighted to hand over to you for the next session. And we look forward to the speakers and to joining together at the end for the panel. So goodbye to Maria and Ellie. We hope that you stay on board, and we'll see you shortly. And it's over to you, Renato.
Thank you. Welcome to this second session. I will now introduce the next two speakers that are Giulia Carreras and Giuseppe Gorini. Giuseppe Gorini is a medical doctor specialized in epidemiology, public health, and biostatistics. Since 2001, has been working as an epidemiologist at the Oncologic Network Prevention and Research Institute of Florence. And since 2020, he has been manager of Cancer Screening Evaluation Unit of the Institute. He has been working in the field of epidemiology and public health since 1998, and he was recipient of many grants from the European Commission for conducting studies on second-hand smoke exposure in Europe, as well as many grants from the Italian Ministry of Health, Tuscany and Emilia-Romagna regions in Italy for conducting tobacco control studies in Italy. Giulia Carreras is graduated in mathematics and statistics and earned a PhD in applied statistics in 2008. And since 2007 has been a researcher at the Oncologic Network Prevention and Research Institute of Florence. Since 2018, she has been collaborating with the Department of Experimental and Clinical Medicine of the University of Florence as biostatistician. She has been involved in several national and international research projects, especially in the context of tobacco control. Her key research activities involve the development and the application of statistical and epidemiological methods in the context of public health. Thank you to stay with us today, and let's go with burden of disease attributable to secondhand smoke exposure in Europe. Thank you.
Thank you, Renata, for the presentation. I'll show you the slides, but Julia will be close to me in order to answer and to speak about the project. Okay, so let's go on the burden of disease attributable to second-hand smoke exposure in Europe. We conducted this study in the framework of the TACSH project, as we already, as a part of the project. And we know that the widely spread of smoking bans in public places in the last decades favored the adoption of voluntary smoking bans in home. And this study was above all on the evaluation of the burden on regarding the exposure at home of second-hand smoke. So the aim of this work was to quantify this burden in children and also in adults for the period from 2006 to 2017 for all the 28 countries, also UK, because we began before the Brexit. Okay, let's move on. The introduction, systematic review. We conducted at the beginning a systematic review in order to study which way our groups estimated the burden due to second-hand smoke exposure. And we identified 72 studies. We saw that most studies were based on the comparative risk assessment approach. And moreover, most frequently diseases studied were lung cancer, ischemic heart disease, stroke, COPD, asthma, and breast cancer for adults. Instead, for children, disease considered were lower respiratory tract infection, otitis media, asthma, SIDC, DS, and low birth weight. We saw that there were very different situations in these articles in terms of estimating the population attributable fraction. Moreover, these estimates are not yet available for some countries, in particular Middle Eastern and African countries. And in some cases, the methodology was not so high, the quality of the study. So after this first systematic review, we began conducting our estimates. So we used, as the other studies, as the method, the comparative risk assessment. That is, the first step is to estimate the population attributable fraction for each disease. Then this PAF are applied to the number of deaths or DALYs, that means daily adjusted life years in smokers for each disease, and then we calculated uncertainty intervals. These are the diseases we considered that had the sufficient evidence of causality and information. So for children, they are almost the same as already said, but anyway, low birth weight, lower respiratory infection, asthma, sudden infant death syndrome, that is the SIDS, and otitis media. For adults, non-smoking adults, lung cancer, chronic obstructive pulmonary disease, the COPD, breast cancer for females, ischemic heart disease, stroke, asthma onset, and diabetes. So this is the diseases. Then, looking at the population attributable fraction, I don't want to explain the formula that is not so easy in some ways, but anyway, This formula contains two parameters: the prevalence of exposure, that is the P, and the relative risk of developing or dying for a particular disease if the person is exposed to the SHS, to the secondhand smoke. Don't look at our, this is the main information we have to do in order to estimate the burden. Then we have to know, as I already said, SHS exposure, that is the P of this formula, and then relative risk, that is the RR of this formula. The prevalence of SHS exposure was in this way. For children, we used the proportion of people with children at home who allow smoking in their house. For the exposure of children in the prenatal period, we use the prevalence of SHS exposure in pregnant women. And then for adults, we use the prevalence of exposure at home in non-smokers on a daily basis. For these estimates, we used the Eurobarometer surveys of the year 2006, 10, 12, 14, and 17. And in the case that we have no data, we apply a multiple imputation procedure in order to fill in the blank data in an accurate way. Then for relative risks, the second part of the formula, for developing death or for dying or developing a disease due to secondhand smoke exposure at home, we use the most recent estimates from the most recent meta-analysis, and for the number of deaths or the number of DALYs, we used the global burden of disease study, the GBD study. Then these are the relative risks considered for children. So you can see, for instance, for all these diseases, the relative risks of developing a disease were around 1.3 to 1.5. And this is, you can find more details regarding the burden of disease for children in this publication on pediatric research. I reported here the paper. So we applauded this type of relative risks. I don't want to enter to the question of SHS assessment, because every relative risk have a particular assessment of SHS exposure. But anyway, for children, we saw that there was a stalling in the period from 2006 to 2017 in the prevalence of exposure at home of children. That was, as you see in the first table, around 10% from 2006, and in 2017 was around 12, but it was almost the same. Similarly, for exposure in pregnant women, you can see that the prevalence remained around 20%. And in the lower table, you can find instead the population attributable fraction for each disease. That means, for instance, for otitis media, it was the proportion of otitis media attributable the years daily years lost for developing otitis media was about 3% of the total years due to the otitis media. So 3% for the PAF for otitis media, about 5-6% low birth weight, 3% for asthma, 5%, around 5% for lower respiratory infection, around 4% of all the years lost for sudden infant death syndrome due to secondhand smoke. So this is the PAF. I know that it is not so easy to understand, but anyway, these are calculation in order to move to this slide where you can see we attribute the number of deaths attributable to SHS exposure in children for 2017 was 335 deaths and 35,000 DALYs. And you can see in the map the proportion of DALYs. It was in a range from 1.4% of all DALYs to 0.7%. And you can see that the value higher than 1.5% were in the darker countries here, the eastern part above all, but also Malta, Slovakia, Bulgaria, Poland, and Romania. Instead, values lower than 0.4% were recorded in the northern countries, in particular Finland, the Netherlands, Belgium, and Luxembourg. Here the same results, but you can see similar results, but you can see the part attributable to each disease. And you can see that the most part of this bar, everybody is for every country, you can see the most part is attributable to the orange one, to the orange part, that is low birth weight. And so you can see that for the highest, as already said, that were in the eastern part of the countries. But above all, you have to see that most of the attributable DALYs were for low birth weight, but also in Romania and Bulgaria, also for lower respiratory infections, that are the yellow part here, that are very bigger than the other countries. Then move on to this is the average in the European Union, 0.7%. And these are instead the part regarding adults. Here we reported the relative risks for each disease. For instance, for lung cancer was around 1.20. For the COPD was around 1.50. The risk of developing the COPD in people exposed to secondhand smoke exposure. And the other one were 1.08 for breast cancer, IHD, ischemic heart disease, 1.14, and so on the other one. You can find more details regarding the burden of disease from secondhand smoking in adults. In 2017, in this paper, we published in Preventive Medicine last year. Then move on to the map of the burden in 2017 in Europe, around 24,000 deaths for adults and more than 500,000 DALYs. And you can see that similarly to the young people, to the children, the eastern part recorded values higher than 0.7% of all DALYs attributable to risk factors. And instead, the lighter countries here, in particular Finland, Sweden, Germany, UK, France, Denmark, Ireland, and the Netherlands, and Luxembourg, recorded values lower than 0.3% of all the DALYs attributable to risk factors. Then this is the same picture for adults, looking at each disease, and you can see that the most part was attributable to the COPD, and then to the IHD, to ischemic heart disease, that is the yellow part. Here you can see the same, the distribution, as I already said, so less than 0.3% in this country in the top part of the graph. 0.4% was the average in all European Union, and then more than 0.7% in that countries here, Poland, Croatia, Romania, Bulgaria. Then the last part, the last slide is on the attributable burden from breast cancer due to smoking and SHS exposure. Here we estimated the burden not only for SHS exposure but also to smoking, and you can see that the part of smoking in this graph is the darker part, and it's almost the most important part. The burden from smoking was and SHS exposure was about $82,000. Of course, the proportion of loss from breast cancer due to smoking was 2.2% on average and only 0.4% for SHS exposure. Highest burden due to both risk factors were estimated in Denmark, Malta, Croatia, Hungary, and the United Kingdom. Instead, the lowest part here, Italy, Estonia, Latvia, Lithuania. Proportion less than 1.5% of all DALYs attributable to risk factors from breast cancer. You can find more details on this part in this publication, this paper published in the International Journal of Cancer in 2020. So, conclusions. The burden from SHS exposure at home is not negligible, both in adults and in children. We have to raise awareness on the health risks in both adults and children. In particular, we have to promote individuals to prohibit smoking, to promote intervention in order to develop smoke-free homes. And that's all. Thank you very much.
Thank you very much, Giuseppe. I see that is still a concerning issue because in any case, the burden of disease, there is a slight increase of this, I saw, even if it's more or less stable, but there is a slight increase in 2017 compared to the previous years. So I would like to ask you, what are your expectations? What do you expect to be the near future and long-term scenario of the global burden of disease in Europe? Because I see that we need more information and prevention campaigns about the health effects. What do you think?
Actually, I see not a real increase because if you see at the confidence of the uncertainty intervals, the estimate from 2006 to 2017 didn't change a lot. But still is not so good as well, because I think that I expect after the epidemics of smoking bans in Europe to record also a decrease of exposure at home. But it happens above all at the beginning of the epidemic of smoking bans. So around the first 10 years from 2000 to 2010. But anyway, I think that we have to monitor, to go on monitoring the burden in terms of looking at the exposure at home. And I think it's enough to go on monitoring, for instance, using surveys, because it's important to understand if this trend will change next year, because, for instance, we have to consider that in the last 5 years, new products, as well as e-cigarettes or heated tobacco products, changed a lot the scenario around exposure to in public places. and also at home, I think. So we need to monitor and go monitoring in order to understand which changes would happen after the introduction of new tobacco products above all.
Yeah, this is a big issue because the second-hand aerosol is also concerning. So the information should be also about this product to the public. Thank you. And do you believe that the general public and more specifically policymakers are aware about the burden of disease caused by the second-hand smoke?
I think that generically people know that it is not good, but anyway, I think that they don't know exactly which diseases are attributable to second-hand smoke exposure, above all in children. So we could use this information in order to increase the adoption of smoke-free homes. In the TACS project, we tried to develop an intervention in order to promote smoke-free homes. It was not easy because it's difficult to enter in a home because it's a private environment.
Yeah.
So we needed to adapt the information or to adapt the message in order to not to be too aggressive in the message because it's a private environment. So it's difficult to, for instance, in Italy, it was difficult to conduct studies with measurement of second-hand smoke exposure using, for instance, at home, these devices that Maria Jose Lopez and May Henderson showed in the previous presentation, because even though there were some parents who wanted to stop smoking at home, they didn't like to have these devices in their own homes. So we needed to have a positive message, similar to what already said Maria Jose, a positive message in order to highlight the positive things that could happen if you implement smoke-free homes.
Yeah, sure. Thank you. Is Giulia wants to add anything to this, Giulia?
No, not in particular, just to highlight, I think Giuseppe has already said everything, but just to say that these results are about the secondhand smoke exposure in homes. So this is the part that is more difficult to monitor, and it's important to highlight the burden due to this private exposure. And answering also to your second question, maybe as Giuseppe already said, several diseases are not really known to be linked to secondhand smoke exposure, especially the low birth weight that in children cause the most burden. It's associated to the exposure of pregnant women. So to SHS, not to the smoking of pregnant women. So it's really an exposure that it's not so much taken into account, and it gives a great burden for children. So maybe all this burden is not really known by the public. And that's all. Thank you.
Thank you very much. If you have any other question, you can write them and we will address them in the panel discussion. So now I will introduce the second presentation that is about best practices to tackle secondhand smoke exposure in Europe by Dolors Carnicer-Pont and Ana Mar Lopez. Dolors Carnicer-Pont is a senior researcher at the ICO Tobacco Control Unit, participates in the Joint Action Tobacco Control #2 of the European Commission, and participated also in the previous Joint Action on Tobacco Control. She has trained and worked as epidemiologist with the European Programme for Intervention Epidemiology Training, and most recently with the Health Protection Agency in the United Kingdom as a locum consultant of communicable disease control, doing epidemiological surveillance and outbreak detection and control. She also worked with the Doctors Without Borders in development and assessment of humanitarian projects, as well as a consultant in the vaccine department for the World Health Organization. About Ana Mar Lopez, she has a bachelor's degree in psychology with a special mention in clinical psychology and a first-class honors master's degree in health psychology. She worked in public health prevention services in the United Kingdom, helping people make healthy lifestyle changes, such as healthy eating and weight management, type 2 diabetes management, mental health support, physical activity, alcohol reduction, and smoking cessation, which is the field she specialized in. In 2022, she joined the Tobacco Control Unit at the Catalan Institute of Oncology as a scientific project manager for international collaborative research projects, particularly within the Joint Action Tobacco Control #2. So welcome to both of you, and let's start with the presentation. Thank you.
Thank you very much, Renata, for the introduction. Let me share my presentation with all of you. Okay. I hope everyone can see the screen and hear me okay. Well, hello, everyone. As Renata said, my name is Ana Mar Lopez. And today, alongside my colleague, Dolors Carnice Pont, we will be doing a presentation on best practices to tackle secondhand smoke exposure and expand smoke and aerosol-free environments in Europe. We will be presenting some preliminary results of a consultation done to experts within the Work Package 8 of the Joint Action on Tobacco Control 2, as ICO, or the Catalan Institute of Oncology, is the coordinator of this work package. I will be focusing more on the logistics of the consultation, and then my colleague Dolors will be focusing more on the preliminary results. So first of all, we wanted to introduce here the guidance document that we have been using to conduct this work. This document was conducted by Work Package 4 alongside with other colleagues from the Joint Action, and it serves as a guidance on how to identify best practices in tobacco control in Europe. It also includes a guidance of a core model questionnaire for identification of potential best practices, and it has also a guidance on how to score best practices. So if we go onto this document and check the definition of a best practice, we will find this. So a best practice is defined as a relevant policy or intervention implemented in a real life setting and that has been favorably assessed in terms of adequacy, so ethics and evidence, equity, also effectiveness and efficiency, both related to the process of the best practice and also its outcomes. If we focus more on the consultation that we have conducted per se, it has been, as I said, a consultation to experts, and it has focused on best practices and also barriers and opportunities for smoke and aerosol-free environments. And here you can see the steps that we followed. So the first thing to do was the identification of experts. The goal was to identify between 3 and 4 experts of a total of 30 countries. And once we had that, we moved into designing the questionnaire. We did that using the core model of the guidance document that I previously presented. And then we programmed the questionnaire using SurveyMonkey in order to do an online questionnaire. Before we launched it, we tested with 7 different Work Package 8 partners in order to assess things like feasibility, duration or clarity of the questions. And then the consultation was finally conducted from the 21st of June until the 12th of September. And the last step that you see here is the one that we are doing at the moment, which is analyzing the results. So it's important to highlight that the results that my colleague Doulos will present later are preliminary results. Yeah, we are still working on them, and it's an ongoing task. We also wanted to show you a little bit how the questionnaire looked like, and it had two different sections. Here you can see section 1, which focused on barriers and opportunities, and this section had 15 structured questions. Here you can see an example on question A1, where you have the question and then different options that you can choose from. If we go on to section 2, which focus on best practices, we have also 18 structured questions. For example, on your right, you can see question F4, but also we had 25 open-ended questions. Here on your left, you have an example on question C1. And additionally, we had questions such as C2Vs, which allowed the experts to upload additional information. So those can be PDFs, web links, or any other sources of information that could complement the answers that they were typing or choosing in the multiple choice as well. So in terms of the data analysis, for section 1, what we've been working on is quantitative data cleaning and processing in order to do a summary report on barriers and opportunities for SAFE. And then for section 2, we've had a few more steps. So first of all, we've done quantitative data cleaning and processing to produce a summary sheet per best practice. And at the same time, we've done qualitative reading and compiling of information that came from those attachments and web links that I mentioned before. And then that information was also added to the summary sheet per best practice. In parallel, it was also done quantitative data for global analysis in order to produce summary tables and graphs for the best practices. If we focus then on the preliminary steps for identifying and assessing those best practices, you can see here that we have those two sources of information. So the information that comes from the answers of the experts and also the additional information from the attachment. And the idea is to do a summary report gathering all this information for each practice, and for that to be reviewed by two different independent researchers and then scored using the assessment criteria of the Work Package 4 guidance. If there is disagreement in the scoring, a third reviewer will come in and will score the practice as well. And the goal is to, after that, gather between 10 to 15 identified best practices and adapt those for presentation and discussion in the Work Package 8 Symposium, which will take place as a pre-conference activity in ECTO in Madrid that will happen in April 2023. So the final steps are that once we have all these summary reports ready for the symposium, in the symposium, we will have a discussion and come to the identification and agreement of the 10 final best practices. Once that agreement has been reached, a web-based repository will be prepared and put in place, and the last final step is going to be the elaboration of a position paper on best practices for smoke and aerosol-free environments. So these are a little bit the logistics that I wanted to share with you. And now my colleague Doulos will continue with the preliminary results. Thank you very much.
Thank you. Dolores, you can start, but remember to switch on the audio.
Yes, hello. Thank you, Anamar. Can you listen to me now? Yeah?
All good, yeah.
Okay. So, first of all, these are, let me see whether I can see. Oops. Where is the screen? Am I sharing the screen? No.
No, you need to reshare.
Okay. The results of this consultation ended up with 40 different practices. 43 experts out of 110 consulted responded the questionnaire on best practices. Specifically, the section 1 of this questionnaire. The results I am presenting is a small view of the section 1 of this questionnaire. We explored the topic of the practice and classified it into different groups: sector-specific bans, outdoor bans, comprehensive, car and children, all these ones. And most of the practices that were informed by our experts were within the outdoor area, and also the sector-specific bans addressing healthcare, hospitality, workplace, school universities, public transportation. So when we look at the title specific of each one of the practice, we have 4 different countries that presented healthcare services practices to be assessed as best practices. Austria presented 2 best practices on hospitality sector, Denmark and Slovenia, smoke-free school hours, workplaces, 2 other ones, and the practices related to public transport, railway platforms, smoke-free train stations, bus stations. We have 3 practices informed. Also, we have outdoor areas practices addressing smoke-free outdoor areas from Denmark and Sweden, smoke-free beaches informed by Italy and Spain, the experts from these countries, 4 different practices addressing children playgrounds, smoke-free sport grounds. Belgium presented a best practice on indoor bans, vape in closed public places, and smoke-free homes. Finally, we have cars and children best practices, quit lines, and other bans that are not addressing a specific areas that are more general, such as these ones as well, comprehensive bans. Here we present the structure index of a best practice. When we will assess whether the practices informed by our experts are candidates to be identified as best, the proposed structure index is this one that contains 10 chapters according to the guidance worked by Work Package 4, and will use this criteria of exclusion or core criteria or qualifier criteria. I'm not going to explore and not going to present further this information because otherwise we won't be able to have a quick view of what was the global analysis of the consultation. Equity and ethical considerations are also two chapters that need exploring by text and narrative reports. So this is not going to be neither presented. When we start with the first chapter, we have the objectives of the practice, and we explore addressing the three different types: conventional tobacco, e-cigarettes, or HTPs. And as you can see, most of the best practices or practices informed are within the conventional tobacco, followed by e-cigarettes and HTPs. And within each one of them, outdoor are the ones that are mostly informed, followed by indoor best practices and the issue of being children, minors in cars. The target population that the practices are addressing are mainly the general population, followed by age-specific and pregnant women. The general population, when the experts answered this, they were meaning not only general, but also it includes other population like children, etc., etc. But if it also includes adults, they answer general population. Regarding the participation, we asked about the involvement of the target population and stakeholders. And we had three different types of involvement: development, implementation, or evaluation of the practice. Here we have the summary of the three types, and mostly public health authorities were the ones that mostly involved in the practice, followed by healthcare professionals and specific target groups. Also the civil society, other stakeholders, researchers and academics, employees, and teachers of schools and kindergartens. Here we wanted to present whether the involvement of public health authorities was mostly in development, implementation, or evaluation. And we can see that international public health authorities and national public health authorities were mainly involved in the development, while the regional public health authorities and the local public health authorities were mainly involved in the implementation of the practice. When we look at the involvement of the target groups, mostly are involved in the implementation and development. Looking at the target settings, outdoor settings, the practices most frequently developed are addressing children, playgrounds, schools, hospitals, bus, stadiums, followed by beaches, underpasses, restaurants, and parks. Regarding indoor areas, the healthcare areas, hospitals, primary care, schools and universities, the hospitality sector. So these are the practices that were informed and the target settings. When we asked about the evaluation, we can see that most of the practices have not been evaluated, and only 35% were evaluated. Sustainability is addressed in only having institutional support and stable human resources in 25 practices out of all the ones that have been informed, followed by the practice providing training of staff in order to sustain the practice, and the sustainability strategy has been considered in only 6 of the practices. Funding was provided by external public mainly, followed by own fund. while 25% of the practices mention not having any fund needed. And finally, the transferability, most of the 57% of the practices were transferred or ready for transfer, and 42% of the transfer was not considered. We also asked about the barriers for the implementation of safe practices. And here we have that only 6 practices mentioned that there was no barrier for the implementation. And mostly the barriers were due to cultural aspects or lobbying of the tobacco industry. When we look at the other barriers, they mention resources, lack of resources, human or financial, compliance and enforcement difficult as a barrier, management, lack of understanding of the importance of tobacco control, lobbying of user groups, and other barriers that were not specified. When we asked about the facilitators, also communication and social media were barriers, were facilitators, such as traditional media, billboards, brochures, social media, were facilitating the implementation of these safe practices, and mostly the support by health professionals, municipalities, and public employees were also facilitators of best practices. So in conclusion, we can say that 1/3 of the informed practices are sector specific, followed by outdoor bans or comprehensive bans. The objectives of the practice apply mainly to conventional tobacco, followed by e-cigarettes and HTPs. Most of the practices apply to general population. The main stakeholders are public health authorities, healthcare professionals, and specific target groups. The evaluation has been done in 35% of the practices. Funding of the practice was provided by external public in 45% and own funding in 35% of the practices. Sustainability is not an option in 30% of the practices, and 42.5% do not consider transferability. And main barriers for implementation are cultural and industry interference, while main facilitators are social media, environmental movements. So we want to thank to all the Work Package 8 of GATC2, all these organizations, as well as some leaders of the Joint Action 2, and to all the control experts that kindly participated in the consultation. Thank you very much.
Thank you very much, Dolores and Ana Mar, for this interesting survey. I wonder how many practices will be identified as best, and especially considering that the outcome, the main outcome should be the smoking decrease. Otherwise, what is the impact? And and after that, of course, it should be ascertained that the best practice, once identified with the European criteria assessment criteria and the related scoring, I wonder how they will be sustainable and transferable. So I'm looking forward to the symposia to see the first results of this. And so I have a question for you. How will the best practices that will be identified, how will be they disseminated and shared for information? of public health professionals and policymakers?
Well, I would say that the 40 practices informed in the consultation will be scored according to the guidance document that was presented by our colleagues of Work Package 4 and also presented at the symposium with and from there it's foreseen that a weight of evidence paper and a position paper will be produced as deliverables of the Work Package 8 Work Package, a joint action within the joint action. We believe that Work Package 2 in charge of dissemination will also be very active on making sure that the people are very much aware of these best practices, and then definitely additional actions are needed to make sure that the member states put in practice and start exploring how or implementing the practice and trying to this happen.
Yeah, thank you very much. And last question is, do you believe that the best practices are indicative of what is happening, or what can be the evolution? What do you expect will be the near future scenario of smoke-free and aerosol-free spaces in the European Union?
Wonder whether Anna.
Yeah, thank you, Renata. Yeah, I would say in terms of are they indicative? Of course, the number of and the variety of the experts, it's important, and we are happy with the information that we gather. We think that it paints quite a representative picture because of the variety of answers that we have. But of course, the most experts that we would have, the wider the picture would have been at the same time. But we think it can be quite representative in terms of having an idea of what is happening at the moment. And then in terms of the evolution, what we are hoping is that once we analyze all these best practices in depth, we find some good best practices. Hopefully, as Renata, you said, that they are strong in transferability and sustainability, which are very important elements at this moment. And hopefully, those can help member states to progress in terms of smoke and aerosol-free environments. But of course, there's still room for improvement, work to do, and guidelines are, of course, needed as well at a European level.
Okay, so thank you very much. Thank you to all. And we are now going to the panel discussion that will be joined by all the speakers and the chairs. So I give the floor to Esther Fernandez, which is the chair of the panel discussion. Thank you.
Okay, thank you very much. I ask all the panelists to join, to turn on your cameras. And well, we are almost on time, and I believe that we have perhaps time for a few reflections, trying to put together several of the data you have provided, results and thoughts you have provided. So, and first of all, in addition to agree to all of you, your participation, and just not to forget it at the end when everybody is trying to escape from the webinar, I would also want to thank Maurice, Renata for his work, for their work, and also those hidden people who have made possible the webinar. Tom from Ireland, and also Olena from Spain, in charge of the question and answer chat, and Tom in the technological aspects of the webinar. But I wanted to bring to the floor one question, and that any of you can respond if you are still. And also, I want to thank the survivors of the webinar, because at this moment we have 73 people from the 100 people that we started 2 hours ago. So thank you to all of you. My first question or reflection, and perhaps Maurice can introduce others, feel free, please, and Renata too. I believe that the common topic between all the presentations related to the burden of disease, related to the exposure, or related to the best practices analyzed is how can we target the people who have to make the changes happen. This is how can we target policymakers, politicians, or even officers in the health promotion departments in the local, regional, or national, or even European level. Any comment about this from any of you? Please, don't be...
Well, it's very difficult. Unfortunately, I can't switch on my webcam. Maybe Tom can... Okay, perfect.
Okay, follow.
Oh, well, my answer is that it is very difficult question at the end, because I believe that it will be extremely important to see the best practices provided by our colleagues in Europe in order to see what is possible to do in Europe. There are some examples that are really important and should be followed by the other countries. Therefore, I believe that such a project within the joint action tobacco control will be extremely important.
Thank you, Silvano. Any other comment to add to this? Well, I also find it very difficult because we have been experimenting this across our academic lives, perhaps, because we want evidence to be used by politicians to inform the changes needed to promote health in general and tobacco control in particular. And I believe that this applies also not only to data when trying to generate data, but also this is the case for best practices. Politicians need to know which is the current situation, which are the practices and interventions, and they work. And then have money and political aim to change things. So, perfect. Also, I wanted to raise another common topic that has been mentioned, that was, well, I will raise two topics at the same time, so you can choose the less difficult if you want. One is smoke-free homes. All of you have been talking about smoke-free homes. We have computed the attributable mortality to secondhand smoke from the estimation in homes. We have been speaking about the exposure, both referred by the population and measured using nicotine in different settings. So smoke-free homes, and we have been talking about even best practices for smoke-free homes. So is smoke-free homes something missing in the change of tobacco control? What do you think at the local, regional, or European level? Can we progress in this topic? No,
well, we
turn of Silvano. Okay.
No, but just to add that we know that the voluntary home smoking bans increase according to the effectiveness of smoke-free legislations in public places. Therefore, I believe that, for example, in England, we observe a fall of the exposure of SHS exposure at home of children over the last 2 or 3 decades. Therefore, we should continue to denormalize in a way smoking in order to obtain home smoking bans, voluntary home smoking bans, as a side effect, let's say, of the legislation, in my opinion.
If I can add something, I think that the big challenge that we have in front of us now is to combine the information or the promotion of smoke-free homes with the problem novel tobacco products in terms of all of exposure to second-hand aerosol. But not only we know that the second-hand aerosol is not as harmful as the second-hand smoke, but in terms of denormalizing the tobacco habit or denormalizing the exposure, we have to deal with this problem, because I know that I noticed that there is in last year, above all, after the introduction of heated tobacco products, that more people begin using these products in a situation where there are other people, without asking if they can use it. For instance, it happened to me in a restaurant, because in the smoking ban doesn't apply to the heated tobacco products. So I think that we have to move, including also the part regarding novel tobacco products, not saying that the second-hand aerosol is very harmful, but in terms of the normalization. But it's difficult to communicate in this way. I think that we need to involve some people who is able to communicate, that is an expert in communication, because we are not, at least many of us are not communicators. So we need to use the tools that, for instance, the tobacco industry begin using 100 years ago. So to use a sort of marketing strategy in order to promote the normalization. So using appealing messages and something that can attract attention from the public. It's not so easy.
Giuseppe, I completely agree with you. And I wanted to add that in 2 studies we conducted, we observed that electronic cigarette users and heated tobacco products users, they used to consume these products. 2 out of 3 users used to consume this product where tobacco is forbidden, and this is the problem. So there are many dual users using electronic cigarettes and heated tobacco products only where it is forbidden to smoke. I can imagine workplaces. In Italy, we have observed that the legislation works, although we found more than 10% exposed in workplaces exposed to second-hand smoke. But however, it works, that legislation. But now we have the possibility in certain workplaces to vape, to consume these new products and also novel tobacco products.
Thank you. Very excellent points, Giuseppe and Silvana. And I believe that Maria or Ellie want to add something.
Yes, well, no, just to the question of smoke-free homes, maybe just to say that so far we have done a lot of research in monitoring, and exposure and so on. And maybe now we have to do more research on design and evaluation of of different interventions. No? And we have to see what can be more effective and to try these new messages. And I think in this sense is also very important what we were saying before, no? This equity perspective to see what can work better for what populations. And I think here there is a very important gap also in research that might be very useful to implement new interventions.
And I just wanted to add also to the question that a way that we could progress, although this might be a little bit controversial as we are targeting private settings at the end, is to maybe those public housing, subsidized public housing, might be a good idea to start like implementing some sort of measure. I know this is some legislation of this sort has been done in the US, and this might be a starting point. Just my guess for Europe, as we don't have anything like that here yet.
Yeah, thank you. Thank you very much. Moving from smoke-free homes, I wanted to raise the topic of smoke-free cars, but there is a comment from the public, from Sheila Duffy from Ash, Scotland, about the evidence on electronic cigarettes, about major health concerns from from electronic cigarettes, and whether we have been addressing this in other projects. And I just wanted to add that, yeah, we have cumulative evidence that electronic cigarettes are not as safe as initially thought. And within the framework of the tax project, we also first measured exposure of bystanders. This is secondhand aerosol exposure in different ways, not only monitoring, complementary monitoring, nicotine in air, also particles, and also metabolites of nicotine and nicotine itself in saliva and urine of people living with smokers or experimentally exposed to aerosols from electronic cigarettes. And also a systematic review that we are still finishing provides a lot of information about different elements present in the aerosols, not only the more studied nicotine and the components of the liquid of the electronic cigarettes, but metals and other potential toxicants. So I believe that all the information that we have been generating, and I think that also the joint action has extended the scope of secondhand smoke exposure to secondhand aerosol exposure. And in fact, we have been talking about smoke-free and aerosol-free environments that I believe it's the birth of a new term that will be used in the near future, hoping also to have legislation at the European level to prompt changes at the national level. So I believe this is also important. So I don't know whether we have, Maurice, what do you think? Time for another question, because I had one about best practices. We have set a taste of what are we collecting in the joint action on tobacco control. But my impression is that best practices are not transferred between countries. Should I say, perhaps they are not shared within countries as well, because many of them were of local scope. And my own impression, I don't know, what do you think, Los, Anamar, and the rest of panelists? What about tailoring best practices or tailoring interventions that would help to transferability and, of course, dissemination? And perhaps this can be the last comment with some of your responses.
Yeah. Sorry. Go on, Dolores. I was going to say from my point of view, it's important to find a balance. So you need to take into account things like transferability or sustainability if we want to move forward on a global level. And maybe we should think about those even at the beginning of designing or starting to think about those best practices, so that we are sure that we have the goal in mind. But at the same time, it's also important to tailor them to a certain point so that they cover the specifics of the localization or the target population that they are going to be trying to help or trying to influence in order to work better. So I think it's a balance between the two.
The microphone, Esteve.
Esteve, we can't hear you. We can't hear you.
Sorry. So I believe that with this, we can almost finalize. I give the floor to Maurice to make the final comment and acknowledge again all of you, Silvano, Alessandra, Eli, Maria, Julia, Giuseppe, Dulos, and Anamar for your contributions, your thoughts, and being open even to be exposed to the questions of the public and also my comments. Thank you very much indeed. And thanks, Maurice. Please, your turn.
So Esteve, just to close, and we might have the closing slide, Tom, if you can find it. I think it's another excellent webinar. We have 2 more planned. They will be in the next autumn because they intersect with the important work of the Joint Action. The Joint Action website has just recently been put up on the internet, and we will be populating this with lots of information for you to join in and to contact with us. But I would just say that in terms of pathways to the future, which was the catchphrase for this excellent presentation, I think now we have a sense of where we need to go, and it's everything together. It's the research, it's about overcoming the barriers, but I think more the enablers. I think the discussion at the end about the enablers, we could do more, and I think we don't share cross-country enough, and I think that we need to move more dynamic about the way we use the broader community. And this came up in the first webinar, you remember, about NGOs and the part they could play. So I think collectively we are very strong. Individually, we are not so strong. So I think that this is the pathway forward. And this is the basis of Joint Action, this brilliant initiative and innovation fronted by the European Commission and all these member states. So it's great to see now so many people join us today. And just thank you to everybody, the speakers, the chairs, all the delegates, and to wish everybody a really happy Christmas. And we look forward to seeing with you and linking with you in the new year. So goodbye from Ireland and goodbye from the HSC and everybody involved in today's webinar.
Many thanks.
Thank you.
Thank you very much.
Bye.
Thank you very much.
Bye.
Take care.
Bye.
Bye.
Thank you very much. Bye. The panel is not to go out, just to have